Okay. Okay. So we're going to do some common reasons why you might have pain after stroke. Trying to understand why it's there and what it might be telling you, and maybe when you might need to go see somebody about it. And then just a couple things that we typically recommend for pain for some of the more common reasons after stroke. All right, so common causes first. And I'm really focusing a lot about the shoulder because with hemiplegia, a lot of times when the arm is weak, the shoulder has a lot of pain. So we're going to talk a lot about shoulder pain to start with. So this is from a paper a couple of years ago. It's kind of a nice Venn diagram that shows you how all these different types of pain could be related and oftentimes are. In a big group of people who had a stroke, joint pain was the most common reason they had pain in 40% of people. And out of that, 20% was shoulder pain. So shoulder pain is the most common cause of pain after stroke. About 10% of people reported headaches. And then a little bit less, the central post-stroke pain, which is like nerve pain or neuropathic pain, in about 8%. And then spasticity, 7% is a cause of pain. And then this very rare but interesting nerve complex regional pain syndrome, it was 1%. You can kind of see in the diagram that these things overlap a lot. And so sometimes when you have pain in your joints, you might also have more nerve pain and things like that too. So there's kind of a lot of overlap here. All right, so here's some fun pictures of shoulder anatomy. So if you haven't seen the bones and the muscles of your shoulder before, this is a little bit what it looks like. There are three main bones, the humerus, which is your long arm bone, your scapula, which is your shoulder blade, and then your clavicle, which is your collarbone. And those three bones come together to make your shoulder. Your shoulder joint itself has a lot of mobility, right? So you can move your arm before your stroke, you can move your arm kind of over your head and behind your back and do all these really good things with it. And there's a lot of mobility in that joint. The joint itself is not that stable, right? So it has a lot of movement, but it's not a very stable joint. And these muscles, these rotator cuff muscles, you might have heard of rotator cuff injuries. These rotator cuff muscles hold your shoulder joint together and basically keep it all together and functioning. And then what happens after stroke when you have hemiplegia, it's not just your arm and your leg that are weak, it's all your trunk muscles too. So your rotator cuff muscles are weak and they're not doing their job of holding your shoulder together. And so really that's probably why shoulder pain is so common after having a stroke. So normally, like I mentioned, the shoulder joint has a lot of mobility, meaning you can move all over the place, but there's not a lot of stability in that joint. Normally, the shoulder blade or the scapula rotates and turns. When you lift your arm out to the side, your shoulder blade rotates along with it. And how that happens is your muscles contract and turn your shoulder blade. And so in your intact side, your shoulder blade is helping your arm and your rotator cuff muscles move so that you don't injure those rotator cuff muscles or have rotator cuff injury or impingement. It's another like medical term for a rotator cuff injury. So that is what normally happens. So after having a stroke, those rotator cuff muscles are not, like I said, not doing their job. They're weak. Your arm might hang at your side initially and kind of be what we call sublux, kind of hanging out of the joint. Or maybe the muscles are really tight because you have spasticity. So you can't really stretch your shoulder the way you used to. And so all of these things go together and really lead to this early rotator cuff impingement, which is just a medical term, meaning that when you lift your arm out like this, it hurts. It hurts early, it hurts in the front and the side of your shoulder. Because those rotator cuff muscles are getting pinched because your shoulder isn't rotating the way it should. So that is basically what this picture shows. So hemiplegia or arm weakness, the arm kind of hangs down from the shoulder joint, and we call that subluxation, which just means the joint is kind of loose. The shoulder blade doesn't rotate, and what this all leads to is this early rotator cuff impingement. And on top of that, if you already have rotator cuff injuries from, years before your stroke, it's probably going to make things worse after your stroke. So, and then of course there's posture too. So posture can play a role in pain, especially if you're maybe sitting in a wheelchair that doesn't really fit you very well. If the chair has a really kind of unsupported seat, it's kind of like a sling seat and it's not really supporting you. If there isn't a good arm support on the side of your hemiplegic arm, like a lap tray or an arm trough or just a pillow, even just something to support your arm. If it's not a well-fitting chair, you might be kind of leaning forward and kind of have this curved spine, and that's going to make your shoulder hurt more because your shoulders are kind of rotated in. And ultimately, if that arm isn't supported, that arm is just going to kind of hang down from the shoulder joint and probably cause a lot of pain. And so the cartoon obviously is a picture of a fake wheelchair that's not very good, and you can see the person is just really kind of curved and not supported, and no wonder she had shoulder pain. But you can also see in the picture on the what was that? That's fun. You can also see here this trough. I don't know if I have a light. Oh, I do have a light. This is this little foam arm trough that you can slide over the arm of your wheelchair, and it would just support your arm. Real nice. Very simple, very low tech, but very helpful. So this is what good sitting posture would look like, right? And I don't have the best posture either, but ultimately, if you are using a wheelchair or sitting in a chair.
Yes.
I get a microphone.
All right, is that better? Okay. So ultimately, when you're sitting, you want to have this 90 degree posture. So you are sitting upright, your hips are at 90, your knees are at 90, your ankles are at 90. So you are sitting up, you are supported, and that'll be a much better posture for you. So this is another picture. It's called a lap tray. And so this is just another add-on to a wheelchair. You just slide it over the armrest, and you can have just a nice wide surface to rest your arm. And also put, a beverage or something. So why does this cause pain? So again, subluxation is the medical term for the arm kind of pulling out of the joint and hanging down below where it should be. And so what this does over time is it puts stress on the shoulder muscles and the tendons. And so it can lead to what we call rotator cuff impingement, so that when you lift your arm up, that rotator cuff muscle is getting pinched. And over time, this can lead to bursitis and tendonitis and rotator cuff tears. So if you don't take care of it, it'll probably get worse over time. So really important if you're having shoulder pain to get it addressed early so that it can kind of get taken care of and you can kind of get to the root of it before you kind of rip up your rotator cuff. All right, so if you do get a rotator cuff injury, what usually happens is it hurts. And so you're not going to be moving it very much. We call that guarding. And so over time, if you don't move it very much, unfortunately, what could happen is you end up with a frozen shoulder. So has anybody here had a frozen shoulder before? Yeah, so I see a couple hands.
What is this?
A frozen shoulder. No? Okay, good. I hope none of you have had a frozen shoulder. So what happens is your shoulder just gets stuck. It doesn't allow you to stretch it anymore. And that becomes a real medical problem, which we have to treat. So we want to avoid that. Okay. Not surgery, but usually we do aggressive physical therapy and use sometimes steroid injections into your shoulder to kind of open it up. So it's a good question. Yeah. Yeah. Yeah, it's a partnership. You get to do a little and then you get a little help. Yeah. So for shoulder subluxation, the arm hangs down from the shoulder joint. This often occurs really early after stroke. So this may have happened when you were still in the hospital and you might not even remember this because it often resolves. It often starts to get better as you get a little movement in your arm, you can shrug your shoulders a little bit. Usually the subluxation gets better. And if you start to get spasticity in your arm, so that real stiff tightness when somebody tries to stretch your arm out for you, it usually actually takes care of the subluxation. So it's really something that I see more in the hospital and the rehab unit. But if you don't manage it early, it can cause pain and then it can lead to those rotator cuff injuries. So that's kind of why I bring it up. You can see on this picture here that there's just this little like indentation in their shoulder. It's not a great picture, but you can see it and you can also get your finger in there too. I can actually put my finger in that little indentation and that's how I know it's subluxed. This is what it would look like on an x-ray. So this is the bone. It should be up here. It should be really closely connected up to the rest of the shoulder. And it's not, it's just separated. How do you go there? You can't fix it, but you can correct it by using a good support in a wheelchair, like an arm truck or electric. Or you can wear a sling. If you're somebody who is able to stand and take some steps, you can wear a sling too. I think I have some pictures of that. Yep, here we go. See, good question. So what can I do to manage this? Move this. Yeah. Kind of move this out of the way. Okay, so now maybe you can see it a little better. So proper positioning. So we kind of talked about the arm trough, the foam wedge if you're sitting in a wheelchair or if you're in bed, put some pillows underneath it. If you are somebody who stands and takes some steps, you can wear a sling. These are some pictures of different sling options. This one on the bottom, whoops, is not great because it kind of holds your arm like flexed and bent, and that's probably not a great place for your arm to be. So you can actually get some of these other styles of slings. Like this one, it's like a shoulder harness, and then you have little hands rest down here, or this one, it's like a cuff. It kind of goes around your shoulder, and they're really nice just to kind of hold it and support it so that it's not kind of hanging. Regular stretching though, really important. And because it might be hard to move your arm all the way, you might need a little help, which is why I say it's a partnership from family or friends or maybe your therapist. Physical occupational therapy can be helpful, especially to keep it stretched and to teach you how to do the right stretches and to show your family too. If it's painful, we can use medications, but of course we don't want to use pain medications if we can avoid it. And then there's this thing called K-tape and stimulation. I think I have pictures, yeah. So I'll talk a little bit about K-tape, kinesiotaping, and electrical stimulation next. Okay, so kinesiotaping is this. So it's usually done by a physical or occupational therapist. What it is these strips of like fabric-like tape that just go on the skin. The therapists will have some interesting techniques, and what they do is they just kind of apply the tape in different positions that kind of mimic what your rotator cuff muscles should be doing. It can be really helpful for pain. It can just give your shoulder a little bit of support, a little bit of feedback to kind of reduce that pain and improve the positioning. So we do this a lot. In the clinic too. When you look at it in research trials, like some people say it helps and some people don't. So I usually say it's worth trying because it's not going to hurt you. It's just tape, right? Electrical stimulation is something else we can do too that might help with the subluxation. It might help reduce pain. It might help stimulate those rotator cuff muscles to kind of start working and pull the shoulder back up where it needs to go. Again, it's usually done by a physical occupational therapist. So it's a little device, a little electrical stimulation device, and they just put the pads on your shoulders. You may have had different versions of electrical stimulation, like on your arm in therapy. Sometimes they'll put the pads and help your fingers open up a little bit or your fingers close. It's the same machine. We just put it on your shoulder. So that's subluxation. Again, that's something that happens pretty early after stroke. If we don't treat it and get ahead of it, you could end up with these rotator cuff things. So rotator cuff bursitis or tendonitis or tear. basically all this means is inflammation of those muscles and the tendons and the bursa around the shoulder. If you don't treat this over time, the tendons will probably thin out and the muscles could tear. And that's, that's really difficult once those muscles are torn. So some studies found that it was fairly common, up to 40% incidence in stroke survivors, but then other studies again found that there wasn't really a relationship. So I think sometimes it depends like who they actually recruited to get into their studies. I think it's not as common as just that regular subluxation where your arm's just kind of hanging down. So if you are diagnosed with a rotator cuff bursitis or a tendonitis or a tear, to manage the pain, we usually recommend something very simple to start out with, like ice or heat, kind of whatever feels better, sometimes alternating like 15 minutes of ice and 15 minutes of heat, like heating pad, kind of back and forth is really helpful, but it doesn't really matter. Honestly, whichever one feels better is fine. Regular stretching, so kind of back to the range of motion exercises, can't really get away from those, unfortunately. You might need to modify activities for a little bit. So if there's certain activities that really seem to bother it, like a certain way that you get dressed, or maybe when you're taking a shower, if there's something that you're doing with your arm that really hurts it, you might have to modify the activity for a little bit or ask for a little bit more assistance until the pain gets better. Sometimes people need to go and do a short course of physical or occupational therapy to really kind of get control of the pain. Again, we can use medication, so your doctor can give you medications, but again, I don't really want to give you pain medicines long term because there's a lot of bad stuff with those. If we try all of those things and you're still hurting, then we kind of move to like a steroid injection. And those are things that like a rehab doc like myself can do in clinic, or some primary care doctors do those. So it doesn't have to be like an orthopedic surgeon or something like that. So surgery is really reserved only if there's a severe tear or all this other stuff doesn't help. And a lot of people don't end up recommending surgery for rotator cuff injuries after stroke. So a lot of conservative management for those. All right, so then we talked a little bit about frozen shoulder, but here is some more information about frozen shoulder. So remember, if you have shoulder pain, over time, it just hurts and it doesn't get better, probably you're not going to move it as much. So we call that guarding, where you're like, hurts, don't move it, don't do it, I don't want you to do it. If you guard it long enough, you're going to lose range of motion. So it will get not just stiff, but the actual joint capsule around the shoulder will get thick and kind of gnarly looking on imaging, and it will actually get frozen. And so in one study, this is a little bit of an older study, but in people who really had painful and stiff shoulders after stroke, like 75% or more actually have a frozen shoulder. So this is the thing we want to avoid, because it is no fun if your shoulder gets stuck. So what can I do to manage my frozen shoulder? So the big thing is to use your weak arm and don't avoid it, because you don't want to get that far down the road where it's actually frozen. So regular shoulder stretching, regular range of motion is the way to avoid it. If you do end up getting a frozen shoulder, you're just going to have to do it anyway, because that's the first line of treatment, is stretching your shoulder. For these, you usually do have to go to physical therapy to start working on that, because it's harder to do at home to really get that aggressive range of motion that we need. These usually require like a steroid injection. So again, a rehab doc like myself, or maybe your primary care doctor can do it, maybe an orthopedic surgeon, but you shouldn't have to see a surgeon. If for some reason all this stuff doesn't work, an orthopedic surgeon can do like a manipulation under anesthesia, but I wouldn't recommend it unless you really have to, because it's pretty painful. And if everything else doesn't work, you might have to do that. But usually we can avoid it with these things. So. All right, so that's the shoulder. Before I move on to other causes of pain, any other questions about shoulder?
I had shoulder pain, but I was released for
It was what?
I know that I can't infection.
Oh, really? Oh my goodness, yeah.
Interesting, yeah.
Yeah, and that's the tricky thing about pain after stroke is sometimes you think you're like, well, it's my shoulder, and then it turns out, oh, I had an infection. And a lot of things do that after stroke. So you'll get an infection like pneumonia or a urinary tract infection, and all these other stroke things seem worse, like I'm weaker or I'm more confused or my language is off. And then when you treat the infection, those symptoms get better. So we see that all the time, and I don't even know how you ever get away from that, because I think your brain can only handle so much. Your brain is like, this is me, I'm doing my best every day to recover from the stroke, and then you throw something like an infection on it, and it just kind of like knocks you out, you know? So yeah, we see that really commonly. Thank you for bringing that up. All right. We're going to look at a couple other common causes of pain after stroke. And these things are interesting. A lot of times we're kind of trying to decide, is it the shoulder or is it one of these other syndromes? So I thought it would be good to just share with you what they are. So spasticity. So I'm sure some of you have spasticity or are getting treated for it. So spasticity, it is an increase in reflexes and muscle tightness after a stroke. So it only affects anything that was weak or hemiplegic after your stroke. And what we think it is the brain is trying really, really hard to recover and get movement back to that arm or that leg. And what happens instead is that it like overcompensates, it goes too far, and you get really, really stiff and tight. So it's pretty common. It affects 23% of stroke survivors, and in up to 30% of stroke survivors, it is problematic. It is something that needs to get treated. It can be painful, it can interrupt your sleep, it can affect your function. And if it's doing any of those things, that's probably maybe a sign that it needs to get treated, right? So what can I do to manage spasticity? So I know Dr. Herman comes sometimes and gives talks about spasticity, so that's like a whole thing. But real like broad overview. Regular stretching, so you can't really get away from stretching. You're going to see that. Everything I recommend is involving stretching. Sorry. You're going to have to do it. There might be certain braces, like sometimes hand braces or foot braces. Very rarely there's a shoulder brace that helps, but maybe. But sometimes a brace can help kind of open up those fingers a little bit. Sometimes we go to therapy, not all the time. Exercise certainly helps, so you don't need therapy to manage it, you should just exercise. There are a lot of really good medications to manage spasticity. So baclofen, you've probably heard of. There's other ones too, tizanidine, dantrolene. There's a lot of really good medicines that help control this. If that doesn't work, then we usually try botulinum toxin injections. So botulinum toxin injections usually are done by a rehab doctor like myself or anybody across this metro area. They really help with spasticity. If that doesn't work, then there's something called a baclofen pump, which is surgery. It's a little bit more invasive, but can be helpful. And then really, we kind of do everything in a stepwise way in order to kind of avoid surgery, only if everything else doesn't work. So, but it can definitely be a cause of pain. So complex regional pain syndrome is the next one I wanted to bring up. So it's also known as CRPS, that's just the acronym. In stroke, it is actually has its own fun name. It's called shoulder hand syndrome. For some reason, and nobody knows why, in stroke survivors, this type of pain affects the shoulder and the hand, and for whatever reason, it skips the elbow, and nobody knows why. So it's called shoulder hand syndrome in stroke survivors. It also has been called reflex sympathetic dystrophy, causalgia. It has a lot of weird names, but complex regional pain syndrome is the most common name. So what it is it's nerve pain, but it's related to like an illness or an injury or some sort of nerve damage. And so in the case of stroke, you have the stroke in your brain and probably some sensory changes and a little bit of weakness in a limb, and the brain, while it's kind of healing and adapting from that, kind of revs up and gives you this intense pain instead. So it's like maladaptive brain recovery at basic level. It's pretty rare though. It only affects like maybe 1% of stroke survivors. This is a picture of what your hand might look like if you have it. So usually the hand is a little swollen. It might be a little bit like red or purple or color change difference from the other side. It might be kind of shiny, and your hair and your nail pattern might be a little bit different. And a lot of times it's kind of cool and clammy feeling too. It's also very, very sensitive. So if you just lightly touch your hand and it burns, that's probably nerve pain, right? So this is what it might look like. So here's a lot of words on the slide, but this is kind of in general what the difference is between just run-of-the-mill complex regional pain syndrome, because people can get this for all sorts of reasons. It's not related to stroke, but like I said, burning pain, increased skin sensitivity, changes in skin temperature, so the one is either warmer or cooler compared to the other side. Color might be different, like blotchy or purple, or maybe pale or red. The texture is different, so it might be shiny, thin, or sweaty. The nail and hair might be different changes on the hand, and it might be just like swollen and stiff. So when stroke specific complex regional pain syndrome, it really, for whatever reason, like I said, seems to affect the shoulder and the hand. There's also a lot of tenderness of the hand joints and with stretching and range of motion. So you just move your hand a little bit and it causes a lot of pain. In stroke survivors, it seems like those who have really severe weakness, like severe hemiplegia and numbness, like sensory loss, and maybe even shoulder issues, tend to be at a higher risk of getting this. So these are the people that I kind of look out for and have a little bit higher index of suspicion that they might have this. And again, here's some pictures of what it might look like. So this hand is really swollen, right? And you can also see it's a little shiny and it kind of lost the hair pattern. And then it's a little bit more kind of pinky pale in color. And then in the palm, it's even a little bit like mottled. Yeah, definitely. Okay, so what can I do to manage complex regional pain syndrome? So the big thing is use it. Use a painful arm. Don't avoid it, because if you keep avoiding using that arm, it's just going to hurt worse. And so it's a little counterintuitive, but what you really need to do is to start to tap and rub and massage the painful arm, lightly at first. This is something that a physical or occupational therapist could help you with, or even just a partner or a family member. Just kind of lightly, we call it desensitization, but lightly kind of tap and massage and rub the painful part, maybe using like a cotton ball at first so it doesn't hurt too bad, but then slowly working up so you actually are massaging it. Regular stretching is really helpful. A compression glove might be helpful if you have a lot of swelling in your hand. Sometimes seeing a psychologist can help. So if there's a lot of pain and a lot of like depression or anxiety related to the pain, it might be helpful to talk to a psychologist. There are a lot of really good medicines that can help with this too. So again, a rehab doctor or maybe a pain doctor might be somebody to see to prescribe some different nerve pain medicines like gabapentin or Lyrica, Cymbalta, amitriptyline. You might have heard these names before. These are all medicines used for nerve pain. There are some injections that might help that a pain doctor might do. And sometimes they help, sometimes they don't though. Usually we can get pretty good control of these other things. So the biggest thing is don't avoid using it. Like touch it, rub it, tap it, massage it. It will help. So here are some things that a therapist might do for complex regional pain syndrome. So contrast that is just putting the limb in like warm water and then cold water and going back and forth. And that shocking of the nerves actually sometimes helps with the pain. Desensitization, again, is that tapping, rubbing, massaging technique that we were talking about. Your therapist might help you do some gentle stretching and strengthening exercises, can come up with different ways to help control the edema aside from a glove. There's like taping techniques that can sometimes help, like that Kinesiotaping. There's a technique that we can use for edema. There's something called stress loading, which is basically bearing weight through the painful arm and doing activities like scrubbing the floor or scrubbing dishes or something. Can also work on like ergonomics and posture, and do some movement therapy and kind of normalize using that arm to kind of get back to using it for functional tasks, improving function, and doing ADLs again with that arm if you can. And then even mirror therapy can be helpful. So, yeah, okay. So mirror therapy is pretty interesting. The idea is there's a mirror box. You can see the box down here. Pretty simple. Honestly, you can just get like those table mirrors from like Hobby Lobby and tape them with some foam or cardboard. Like it's not fancy at all. So you make a mirror box and then you put the hemiplegic arm, painful arm in the box, and then look at the mirror image of your other arm that's working a little bit better, and you do exercises. You do exercises while your arm's in the box. You're trying to move both arms, but your brain is seeing the mirror image of your arm that works a little better at the same time. And so what your brain is seeing is movement, and that actually helps with pain. So this is a technique that we use in our therapy gym. This was one study that they looked at 48 people who had an acute stroke who had pain, and they did these visualizing exercises with a mirror, and then they compared it to a group that didn't do the mirror. So they did the same exercises, but they just put a cloth over the mirror. And they did it for 4 weeks every day. And then basically what they found is, in this graph here, you can see that their pain scores went down. So at baseline, both the people who used the mirror and the people who didn't use the mirror had about a 7.5 out of 10 for pain scores. And after 4 weeks, the group that used the mirror, their pain score went all the way down to 4 out of 10. And the people who didn't use the mirror didn't really have improvement. And then it's hard to see on this picture, but at 6 months, they still had pain, which is pretty cool, like 6 months later. So I think mirror therapy is really helpful. All right, so neuropathic pain, or just central post-stroke pain, is a little bit more common than that complex regional pain syndrome. It's just basically pain that occurs after a stroke in any area of your body that has sensory loss. So if you had an area that had numbness after your stroke, chances are you could have nerve pain. Again, the brain interprets numbness in a really funny way and substitutes pain instead of numbness in a decent amount of people. So any part that was numb after the stroke might have pain. Typically, if it's really central post-stroke neuropathic pain, it'll affect half of your body. So if half of your body was numb, then half of your body might be painful or tingly or burning or any of those words, cold, sensitive. That could be neuropathic pain. So in this one study, it probably affected up to 8% of stroke survivors, and it was really a problem. Like it was interfering with their daily lives at about 5%. So again, burning is the most common word that people use to describe this, but it can also be aching, it can be tingly, lots of funny words, but very, very sensitive to light touch and cold especially. It can get worse if you move it. It can also, your pain can also be related to your emotions. So if you're struggling and you're just not feeling so hot, you're maybe feeling a little depressed or a little anxious, your pain might be worse. The two are definitely related. So managing neuropathic pain is very, very similar, in fact, it's identical to complex regional pain syndrome because they're both kind of versions of nerve pain. So again, you want to use the painful side, don't avoid it, don't leave it alone, you actually want to force yourself to use it. You want to tap, rub, and massage the painful side, gently at first, but then hopefully over time you can tolerate an actual more of a massage. I've even told people to get like one of those handheld vibrators, you know, like a back massager vibrator, and just put that on the painful part of their arm or their leg. It does seem to help. So, regular stretching. So sorry, can't get away from stretching. You might need to go to therapy, you might not. It kind of depends how bad it is. Again, psychology, European psychology can be very helpful because it's very pain and mood are very much linked. So if you're struggling with pain or mood, you might need to deal with the mood and the pain, right? Lots of good medications for neuropathic pain, very similar ones to the complex regional pain syndrome. So gabapentin, Urica, Cymbalta, there's a whole bunch of them. And then injections, so not very common, but possibly pain doctors could think of some injections to help. So this list of what a therapist might do for central post-stroke pain is the same as complex regional pain syndrome. So we kind of went through this list already, but it's very, very similar. Neuropathic pain at the end of the day is, again, the brain interpreting signals the wrong way. All right, so those are almost all of my slides. So take-home points are, pain is pretty common after stroke. It's okay. It's not your fault if you have pain, but if you have it, there are some things we can do to make it feel better. So I would reach out to, your doctor or your therapist or somebody that might be able to kind of get you a good diagnosis. Because if we can diagnose what's causing the pain, we might be able to help it. So things you can do on your own if you have pain. My biggest message is to use the weak side at all. If you can, even a little bit, don't avoid using it, especially if it hurts. Because if you use it more, it'll help it move better, it'll help the pain go down. So try your best to use that side as much as you can. Try to have good positioning and posture when you're sitting, when you're walking. If you need a sling or a brace or something on your wheelchair to make that better, let one of your doctors know, because we can, or therapists know too, because we can get that for you. Definitely regular stretching. So if you're not stretching your arm or your leg every day, you should probably do that. So I don't know if anybody doesn't want to do it, but you should probably do it. Ice and heat can be helpful if you just have some pain and you're not sure what it is. Ice and heat are never going to hurt you. They're always going to maybe help. And then talk to your doctor about other options. There's probably something that can be done for your pain. So better to treat it early and not avoid it. So I have to make a little plug for physiatry or physical medicine and rehabilitation doctors, which is what I am. This is what we do. We diagnose and treat pain after stroke. We prescribe physical and occupational therapy. We can prescribe different medications. We can order braces, positioning devices. We can do some injections. And really we can refer you on to like a surgeon or a pain anesthesia doctor if you really need to. So that is just a plug that if you have pain, you should probably might think about seeing one of those. So again, this is that diagram. So again, it shows you that big circle is just musculoskeletal pain or joint pain. The smaller pink circle is shoulder pain. So it's a pretty big part of the circle. And then those other things we talked about. So neuropathic pain, spasticity, and then we talk about much headaches, and neighbor headaches is also part of it too. So they're kind of related. They're definitely like all part of recovering from a stroke. All right, so that is it. So that's me, and then that's Dr. Herman, who I know also comes and gives talks here. So we're kind of the two stroke rehab people at KU. And there's also wonderful stroke rehab doctors at St. Luke's and other places across town. So I'm not just saying come to KU. But if you need to get in, that's the number for our phone line. So any questions?